Well, as Josh had mentioned, my name's Tyler Mackie, and simple fact, y'all are still sitting in here for the insurance guy and the doctor. Well, thank you very much for attending. Most folks were very inspirational and motivational. Hopefully, I'll be bringing some clarity to a subject that's affecting a lot of folks. The view that you're getting this is my disclaimer early on. You're getting a little bit of an industry perspective on Obamacare or the PPACA, the Patient Protection Affordable Care Act, and how it affects health insurance. Health insurance is something that's everybody's got or trying to get or hoping their employer provides or something like that. So we got a lot of ground to cover today. What I'm basically wanting to do with my section of this is make it a little bit more forum style. So because of the content and the time frame, I'm going to keep it as interesting as possible, but I also want it to be interactive. So if you've got a specific question, raise your hand. Try to keep it general in nature. Don't go into, hey, I got a goiter or something like that. That chip is on after me. I'd be happy to answer all those questions. But we're going to be, covering a lot of the different avenues or areas of health insurance and how you get it and how it's provided and what direction you may need going further to figure out what's going to be the best for you. I hope that as you go away from here, you either are more confident in the plan that you have or at least have some direction in where to go forward with that. And and I've got notes all over this. I've passed these out, so if there's not one at your table, look around and we can make sure you get one. Okay, so, and then also continuing on my disclosure, I'm a broker. I represent basically every major medical insurance company in this area. I'm not employed by them, so I'm not speaking on their behalf on a lot of this. And again, a lot of what I'm going to be speaking about is in fact opinion and also can change. I'm going to keep a lot of the political views out of this as well, because essentially what I'm going to try to speak to you about is what we know today. Because if you were around Monday, some things have already changed since when I started preparing for this. So exciting, that will be the exciting point to this is, are we up to date at the end of the meeting? So so that's what I've kind of done in this, and I'm going to be a little bare on slides and everything because I really want us to just kind of move through each category on your handout. We're going to start with the different ways that you may have health care. And so if we get into these, you can kind of see what some of the reactions that the industry has made. And as somebody said earlier today, Obamacare, does anybody even really know about what that is? It's an ever-changing animal. We're going to start here at the top of large employers. I've put them first because there's less to say about that than anything else right now. As of Monday, they've delayed the mandate. It was January of 2015. They pushed it back 1 year to January 2016. So a lot of what you've heard, and really this is where a lot of folks get the biggest hype with the penalties, access to employers, and they have to provide coverage. Now, large employers cover several ranges. When they say large group employers, they mean 50 full-time eligibles. And full-time eligible is a calculation that you really kind of need your CPA or your tax advisor to help you with. But that can go all the way up to somebody like Eastman that employs thousands. Now the rules are a little different now that they've made this amendment. They've kind of really pushed down on a little bit more of shared responsibility. So you see in there, the mandate's delayed, but this shared responsibility starts January 1st. And this is a very inside the industry term, shared responsibility. What it means for 2015 is the employer is responsible for making sure 70% of his employees have coverage. A lot of what we're talking about today is, this is the rule, how do you enforce it? It's a great question. I don't know how they're going to enforce that, but they don't have Obamacare police yet that I know of. And then by 2016, 95% of the employed personnel of a large employer has to be covered under the plan, under a plan or the plan. We again don't know exactly what that looks like. Guidance hasn't been out on that yet. A lot of these things, just like if you were in the health insurance business, I know you were, back at the first of the year, we've kind of found things out a month after they happened. We had the big grand rollout in October and November for Obamacare, which was re-rolled out in December, which was re-rolled out in effective, glitch-free, hopefully, January 1. So a lot of these things that we're finding out is a lot of time right as they're happening. And that's what we're kind of seeing now with the large employer. And I think part of the reason that was delayed on the mandate was because they're trying to buy themselves some time to figure out how they're going to implement it. Moving down a little further to small employer plans, this hits home a lot more. Yeah.
Okay, so question. Are they using bigger companies and insurance professionals like yourself to get input, or is it just government trying to figure it out?
I would say that they do, because you've got a lot of vested interest by companies as to what their decisions are. So I would say that they're using a lot of consultants for that. We're not privy in our side of the business exactly how they come across making these plans, and I don't really want to speak to the government's direction on that. But yeah, I would say that they're getting input from all these large insurance companies have lobbyists. Okay. Small employers make up a large amount of who we work for. They make I'm a small employer as well. They make up a lot of where we get our paychecks, and a lot of us in here may be small employers. So small employer plans are a hot topic right now, because as of January 1st, the regulations, the rules and regs and the mandates applied to small employers. Now, unlike large employers, they don't have to offer group coverage, and there's no penalty if they don't. But they do have to offer plans that fit a certain guideline, and that's what we call essential health benefits or essential benefits, ESB you'll hear. So on renewal, if your renewal wasn't January 1st, if you're a group under 50, when your renewal comes up, March, June, later on in the year, you will more than likely be required to offer essential health benefits on your plan. With the caveat that because you had to drop your plan, then you could, if you like your plan, you can keep your plan, and the rules were reversed. Some groups are actually getting offered, you can keep your 2013 plan for one more year. So I'm giving you a rule and an offer, and then I'm backing it off the table and saying that's not necessarily true. So again, that's why this is an ever-changing animal, but that's the rough guideline for a small employer group. Again, under 50 full-time eligibles. What that looks like is pediatric dental vision is included for routine care, and then also they have a deductible cap of $2,000 per individual, $6,350 on the maximum out of pocket. We're moving toward the deepest part of our conversation today, which is going to be the individual plans, individual mandates, and that's probably going to be where most of the questions come from, because that's really the hot topic right now. But I'll echo back to some of this, because that's really what's going on right now in this next 6 months, is really hot between small group plans and individual coverages. Medicare coverage, I put this one in here up a little higher just because it's an easy knockout. Not a lot's changing to Medicare. I get questions every week, hey, how is Obamacare, how's PPACA, how's the Affordable Care Act, how's that affecting my Medicare? Am I going to be penalized? Is my plan good enough? Basically, they're kind of exempt from any of the qualifications or mandates. They don't have to have certain plan designs. Most of them have better plan designs than you and I anyway. So Medicare, for the most part, the 65 and older folks on disability, they're not really having anything to worry about. There are some changes there. The pharmacy coverage gap is closing, the donut hole, if you're familiar with that. It's going to be getting smaller every year up to 2020, and it's supposed to go away. And then really on the back end is the durable medical equipment piece of it, which is your wheelchairs, walkers, hospice, and home care are going to be seeing some pullback on what those are provided through our Medicare system. Whether the insurance company is going to step up and cover that gap or not, we're unsure, because that hasn't actually started. It's planned to go into effect next year. That's where a lot of folks politically minded get into the death panels, things like that, and end-of-life planning, and how that's attacked. That's where they got that for the most part. Okay, moving right along. We're making good ground here. Exciting stuff. Medicaid and TennCare. Now, I broke this out separate from Medicare because Medicaid and TennCare are typically folks with chronic conditions or lower income. And TennCare is the state, previously, the state vehicle that rolled that out. What we're seeing there, and this is really, this has been hot topic because if you follow state politics, Tennessee, Virginia, North Carolina have not expanded state Medicaid. Or into the federal Medicaid program. Medicaid's always been ran by the state. And so part of this was the Supreme Court ruled that states make their own decisions as to whether they're going to buy in on this, this federal expansion of Medicaid and take money from the federal government and let the federal government run that. Now, there's a lot of red tape and sticky as to why that would be a good idea or why that'd be a bad idea, and that's something Haslam is wrestling with right now. A lot of folks get really worried that it didn't kick off January 1st. That's no surprise. Legislature left before even deciding on that, so they couldn't have reconvened in December to make that a January 1st effective date. If they did, it couldn't have been implemented by February anyway. I'd say we will hear something on state Medicaid expansion in the next month or two, and we'll know more about that. Why that even matters to you, I'll go into a little further here in the talk. Yes?
I have a question. My son and his wife are having a baby in March. She's on TennCare. Their income is low. She's still in college. John tells me that in order, he can't sign the baby up for TennCare until after he's born. And he said he was told you had to go through healthcare.gov to sign up for TennCare. Is that true?
Yes and no. It's not the only avenue too. It's going to be the more mainstream avenue going in the future.
It's not a secure site.
They have had security issues in the past. I can't speak to the level of security as is now, but it has been improving. You can enroll over the phone or by paper, though.
Do they put the data? Why does TennCare have to go through the federal government? Why are they doing that?
And that's as probably over my knowledge base on why TennCare has to use something like that. But part of, well, really, and a lot of folks think healthcare.gov is logging in straight to the government. In all actuality, it's very much a state-based system right now, and probably will remain that way for a while. It brings up state-based plans. It goes into a state-based database statewide. It's not. It is federal government administered, but it's very much a state-based system. So that was just the primary due to the age of the folks rolling onto healthcare.gov plans. That was the best way for them to get it out. And brokers like myself use that system daily. We enroll folks through the website. We enroll folks via paper applications, and then also over the phone if the security is a concern. Yeah, I hope that answered your question to a degree. And we do know TennCare's changing. We don't know what that looks like in scope yet, but we do know that TennCare is going to be getting some new names and things like that. Part of the Medicaid expansion is moving into higher income brackets, and really, to speak to your point, a lot of kids and newborns that are already on a TennCare system or through healthcare.gov, they're automatically put on Medicaid for the first 6 months. And in my thought process, and why I can reason that, and I haven't had it verified by any insurance companies, but it was part of the negotiations, is if we're going to provide you guaranteed coverage to the family without any underwriting, any pre-existing conditions, any child or pregnant woman that we know is an automatic bigger claim, then the state's going to have to cover that cost. And that reasons out and makes sense to me, because if you go through healthcare.gov and you put in that the individual's pregnant, it will almost default every time to a Medicaid coverage for them and their newborn child. Great segue into the next portion, which is the individual coverages. to give you a little insight into my block of business, I have probably sold 10 times individual plans in the last 60 to 90 days than I have in my whole career. Just because of that being the thing that people are opting into, or small groups are dissipating and rolling their group into individual coverages. And I'm not going to be making a lot of blanket statements or advice today like, yeah, everybody should drop their small group plan and roll into an individual plan. All these things are subjective to your group, and we've advised folks to keep group plans. But what dynamic this has created, whether intentional or not, is you have small groups, and this is very common. A small group, a professional firm, or even just a management group in a non-professional atmosphere, but they're having trouble keeping their claims down. And so, say they got 12 people on their plan, then they got a group of 20 altogether, and so they have trouble with participation, because you have to have 50% of your employed full-timers on the plan. You got 20, you got to have 10. So if you got 20 in this group that we're talking about, and you're teetering between 10 and 12 every year, you go down to 9, you lose your group plan just out of participation alone. And then, so you're teetering here on 12, or you might even have less than that, and a few of them have a baby, and you got a diabetic on there, and another guy has a heart attack, which is not uncommon for a group of 20 people. You see the rates start skyrocketing, and so the employer is having a hard time paying their percentage, and the employee doesn't like their cost because it went up because the group is so small and you don't have an opportunity to spread some of that risk around. So you get a high rate increase, so the knee-jerk reaction is to raise the deductible. So you raise the deductible, which makes the plan less attractive, which then causes them paying the same price for a less attractive plan, so less participation, you might lose your group anyway. I hope y'all kept up with all that, but you've probably been through some of that. So, and we're even seeing this with larger groups too. So for the last few years, we've been playing this little dance of, okay, how can we manipulate these benefits to keep the price down but the benefits up? And we're in a smaller market. Some might call this a medium market for health insurance, but a lot of the large players don't offer small group coverage. You really only have 3 here. You have Blue Cross Blue Shield, United Healthcare, and Humana. So you've got your choice of 3 almost every time, and you kind of shop, move around, do what you can with your plan to keep it attractive. But what we're seeing now is we have the small employer mandate. They can't raise their deductible over $2,000. So if you have an HSA plan or a high deductible health plan with some type of savings account attached to it, $2,000 is your cap, so your premium just went up, and now your employer goes, well, I can't continue contributing to an HSA plan. For small groups, we may actually see HSA plans go extinct. They're endangered now, but they may go extinct. And then what we're also seeing is a lot of these companies are weighing their options and going, well, I can drop my plan as an employer, let these folks, who half of them aren't even on the insurance anyway, go and get it through the marketplace or off marketplace, and they can pick it up with no underwriting and no pre-existing as of January 1, and then they will actually get a subsidy if I step away from my plan and don't offer one. I've kind of got myself ahead of myself there, because on the individual side there are different paths, and I kind of branch these off into 2. There's others. I should have put an other category down there. But for the most part, what you're looking at is 2 paths. And about the same players in the small group side as the same players in the individual side. We basically have the same companies there. But individual plans, as we talk a lot about, and really kind of the title of this is Obamacare, is your marketplace plans. This is your healthcare.gov plans. So this opened up officially, I guess, toward the end of last year, efficiently opened up at the first of the year. And then we have the open enrollment set to close March 31st. And then there's a couple more toward the end of the year, but we're probably going to be seeing an open enrollment once to twice a year going forward, allowing folks to make shifts to their plans. But the marketplace plan, and this is one of those buzzwords that came out this year, marketplace. Marketplace just means you purchased it through healthcare.gov. That is the marketplace. They wanted a little better buzzword, and they got out in front of it before somebody called it the Obamacare.gov or something like that, and they wanted to call it marketplace plans. There are no underwriting. So if you purchase a plan in 2014 that is considered an on-marketplace or off-marketplace plan, there's no underwriting involved. They can rate you up and do rate you up based on tobacco use. But if you're a diabetic, you're paying the same price as an Olympian. If you're pregnant, you're paying the same price as a male your same age, unless that male smokes. Smoking rates are very, they gouge that pretty good. And a lot of folks complain about it, but I don't even understand why that's the one thing they picked out, but they can. These are, if you go through healthcare.gov, or if you're looking for a subsidy, or your tax credits, this is the first time that we've seen premiums are income based. And so if you go through healthcare.gov, your premium is based on what your plan you pick and your income, and whether you're a tobacco user or not. And then on top of that, they're metallic plans. You probably heard the bronze, silver, gold, platinum plans, things of that nature. And that's just their identification for the level of coverage provided. I have a list of the ones that are available, platinum plan or the metallic plans. Interesting enough, if you purchase one through healthcare.gov, a Blue Cross Blue Shield Silver plan, it's the same plan code and the same plan as if you purchased it off marketplace and went directly to Blue Cross Blue Shield. The difference is you get a subsidy based on your income for one, and the other you don't. You pay full price regardless. So that kind of leads us down here to the off-marketplace plans. Let me put one more caveat there. Based on your income and to dependent ratio. So you've got a mother of three, and she's the only income for the household. There's a good chance, and a lot of times you'll see this happen, if the income to dependent ratio doesn't match up, they will actually pull the kids off onto the CHIP plan, which is the Children's Health Insurance Plan. It's a statewide plan that covers children until they're 18. Some folks look at that and they're like, well, I'm not real happy about that. Or some folks are fine with it because essentially they have just as good or better coverage than the spouse or the parents. Or some folks see that as a beginning of putting everyone on a single payer system. So that's, and then again, as I mentioned earlier, for pregnant women and a lot of times newborns, they'll immediately default to the Medicaid system. So as you go through healthcare.gov, if you qualify for a subsidy, you get an eligibility notice, and it kind of shows you how everybody falls in line there. Yes?
Will the subsidy be available next year if you have employees that do not sign up for Obamacare this year by the 31st?
Yes.
Do they sign up next year? Is that still available?
From what I know now, the subsidies are a subsidy or a version of subsidy is going to be in place for the long haul. We're going to have an income-based plan cost, and even for folks that have either high dependence to a low income ratio or just lower income altogether. I've been meeting with a lot of what folks would call working poor. They're in the middle 20s. They would be in the invincibles. As a lot of folks know, they just hadn't had insurance because they're 22, 24, and they're on their parents' plan or whatever, and they make $12,000 to $14,000 a year. They're paying a very minimal amount for their health insurance because of the ratio there. But also, they not only have a cheap premiums, but they get cost sharing. So when they go to the doctor, they're not paying the same premium or the same copay as you might pay. They're paying less or nothing because their income to ratio is a lot lower. So cost sharing is a part of that. I didn't break it down all the way on here as to what that looks like because more folks are just looking for the path to get there and which direction they should go. So the second piece here is the off-marketplace plans. These are folks who may have done their calculations in advance and realize they don't qualify for a subsidy. They may already know they don't qualify for a subsidy based on their income, or they may not want subsidy. There are those folks that I don't want what's available. I don't want to go through the website. I don't want the subsidy. I don't want to be a part of that system. So they're going through Blue Cross Blue Shield directly, Humana directly, a few other companies directly. Those are off-marketplace plans. I broke those down into 3 categories because that's really where you see your biggest range of what can be penalized, what can be covered, and things like that. The first one are the 2014 plans. These are plans you'd purchase that are off-marketplace after January 1st. They fall into the metallic rating, then they have no underwriting. This has been great for diabetics. I had a diabetic lady moved here from Florida the other day, saved her about $1,200 a month on her health insurance plan. She qualified for no subsidy. She just was paying out the nose for coverage, and we actually improved her deductible. She's paying out the nose for coverage because the company rated her up so heavy because she was a diabetic on a pump, and she could afford it. So this is great news for folks like that. Then again, no underwriting metallic plans. Those are based on for running these. Really, all we get is the age of the person, and then if they use tobacco or not. So it's very simple. The underwriting, the process is very simple. It takes about 24 hours to get a turnaround on that. They just need to scrub them through the system. The second one is grandfathered plans. We heard a lot about these last year. If you like your plan, you can keep your plan. If your plan's a grandfather plan, did they lose your grandfather plan? You're not a plan. Now you can't keep it, but you can get back on it now if you want to, but if you keep it, you're going to be penalized. Grandfathered plans are few and far between these days. I can't tell you, I can't put my finger on a whole lot of them because they are plans sold before January 1st that meet the requirements so they're not subject to the penalty. They're non-metallic plans. This is what we used to sell for years. We'd be able to design a plan. You walk in and you said, I want this copay for that and this and that and that. Now, we don't do that. These are underwritten plans. You went through underwriting. You may have some exclusions on your plan. You went skiing, you jacked up your knee, you've got an exclusion on that knee. You're on a grandfathered plan. And then underneath that there I put the non-grandfathered plan. Same kind of deal, underwritten, you had pre-existing conditions. It's a non-metallic plan. You don't have a silver or gold attached to it. And these are subject to penalty. The first one that comes to mind is the Farm Bureau TRH plan. They only want the cream of the crop. I've had that plan for a while. I was the cream of the crop, I'm not now, health-wise. But these are plans that you may enjoy. They may be great priced, the benefits may be good, but they don't meet the standards for PPACA, and they are subject to penalty. So that's one of the types of plans that are still out there. Yes?
What's the open enrollment issues? Let's say you have employees that their rates are bad or they don't want it. You're not going to be able to keep it as a company. Is there an open enrollment issue to move them onto the marketplace?
As far as right now, we've been timing. Let's say we meet with a group and they, and this is, we've been doing this since January 1. Timing the dissolve of a group plan. Okay, we've done the math backwards and forwards. This is going to be a great move for us. It's going to be a great move for our employees. It's going to save some money, and then we can enhance them in other ways. You have to enroll by the 15th of the month to get coverage starting the first of the next month. So this Friday or Saturday, I'm going to be very busy on Valentine's Day because everybody's scrambling for a March 1st start date. And we have some groups that are dissolving their plan effective March 1st. To do that efficiently without having anybody have a staggered coverage or gap there, then we're having to plan the dissolve of the plan in advance so we know that everybody gets their enrollment done by the 15th individually. And so if March 1st they can start their individual plans and lose their group coverage. One of the other added advantages to that, the group has less responsibility now. They don't have to worry about the payroll deduction. They don't have to worry about is their plan compliant? Is there a penalty going to be involved with their plan? Unless they're a large employer 2 years from now. So there's a lot that goes into it. In my mind, what we're probably going to see, because we haven't had guidance on it yet, in the future, because they're trying to get the numbers up on these marketplace plans, I'm seeing that they're going to have special election periods for groups that drop their coverage throughout the summer when there's not a special enrollment period or an actual enrollment period. So we're probably going to be seeing something like that. Much like now, if you lose your insurance, you've got COBRA, or you can move over to another plan without any health questions.
Will COBRA disappear once all this is in place?
There will be some form of COBRA or state continuation, at least for the short term. Right now, a lot of folks that have been paying COBRA, and if you're familiar with COBRA, that means you're paying both sides of the premium. If you left Eastman and they paid 70%, now you're paying 100%, but they're administering it for you through Eastman. And same with most others. So there will be some sort of COBRA. Is that the 5-minute bell? Okay, good. I'll say, just cut you off, Chip. So there'll be some sort, but a lot of folks have found their rates are cheaper individually now. Yes?
I keep hearing the networks under these the metallic plans, especially for the bronze and the silver, are smaller than the networks have been traditionally. With fewer doctors, hospitals, and specialists. Has that happened here in Tennessee yet?
Great question, and no. If you carry Blue Cross right now, you're on the S or P network. If you live in Knoxville, you're on the E network, which is a new network. Most all the plans that you're purchasing up here, unless you're buying a multi-state plan. I speak to Blue Cross because if you go through healthcare.gov, unless you're in a county that's a little bit removed from here, you're buying a Blue Cross plan. They are the only company in this area on healthcare.gov. They got their numbers in, or their paperwork in faster than everybody else. You get 3 options if you're in Knoxville, about 4 options if you're in Nashville, and a couple more over the state line. So, so to answer your question shortly, no. If you went through healthcare.gov, you're on the S network, you've got the same doctor I do. You got the same doctor anybody else with Blue Cross does. In the future, are they going to discriminate against that? I don't know, because as the negotiations go along with reimbursements and things like that, we may see it revert more to like a Medicare reimbursement, and we may have to docs may have to see more people to make the same dollar. Let me scoot a little further forward. So folks ask simply, well, how do I know if I fall into a subsidy category? Or what's this Medicaid expansion you're talking about? Well, when I stretched this map out, it actually moved this bottom and the top over. But basically, the highlighted column is everything to the left of the highlighted column. The first one here, the lower incomes, that's Medicaid expansion will go up to that amount. So those folks will pay very little for their coverage up to those income amounts per household size. On this other highlighted section, everything to the right, you're basically not going to get a subsidy. So if you are a family of 4 and your modified adjusted gross income is $94,500, you're not going to be eligible for subsidy. And this is a rough guidance. You may run the numbers almost exactly here, and you may find it's 1,000 one way or another. That's just the way that. And again, there's certain things that are going to throw that off if somebody is pregnant or something along that line.
What makes up modified adjusted gross income?
Great question. You're like a plant. Modified adjusted gross income, or MAGI, is basically any source of income. They look at municipal bonds. They look at it's above and beyond your non-taxable incomes. They're counting those as well. If you're getting subtle income from a company, that's counted as well. Things that aren't counted, and this is again yes and no. I don't know. It's Social Security disability a lot of times is on the fence as to whether it's being counted. You'll run one on healthcare.gov and it'll count it, one it won't. There's still glitches to that system as well.
How about passive losses?
That's getting a little sticky. So whether it, how you would roll forward losses from previous years and things like that, capital losses, and how it would affect your modified adjusted gross income or your AGI. I would probably even talk to your accountant in there and say, listen, how is this affecting my modified adjusted gross? What do I need to tell my insurance guy on this? I've got a disclaimer at the bottom of that just for those kind of questions. Okay, well, just kind of let me add a couple things in here. 2 great resources as well as the Kaiser Family Foundation, kff.org, not kff.com. That's a totally weird something else. It allows you to put in your calculator, your income, your family dynamic, and it'll spit out what your subsidy would look like. And then secondly is the healthcare.gov website. Feel free to work with an insurance person on that. You pay the same price, but they're going to make sure you don't have operator error. So as we're talking about changes and things like that, it kind of led me to meet Chip Backus. And Dr. Backus is created another program, a fee for service type thing that implements great with folks who are insured and also small business owners trying to bring value to their benefit plans and self-insured larger companies that are trying to keep their bottom line pretty but make sure their folks are going to the doctor and staying healthy and the preventative piece is taken care of. I don't want to steal all his thunder, so I do want to bring Chip up here. But Simply Healthcare is his brainchild and baby, and it works out really great with what we've seen in the market, and a lot of folks that go, how can I get the best value? How can I make, what if I don't want to play in the system? What if I just want to work out something outside of that or to complement the plan I have? And you want that?
You're going to make me wear the mic?
I am, yeah.
All right. Thanks. I'll try not to bore you too much. This is really not a pitch. This is just more making you guys aware of some options that are out there. Well, options that may be starting. Anyway. So I'm an emergency physician in the area. I'm out of Holston Valley in Bristol. And I realized... And I know all this stuff is making a lot of your head spin. It had made my head spin, and so that's what made me want to try and change and do something. And Tyler's great. Dan is here also. Great resources to try and help clarify some of these things that would make business owners' heads stop spinning, because I don't know about you, but I'm tired of hearing about Affordable Care Act. I'm tired of hearing about Obamacare. I'm tired of hearing about how our rights are going away and we become socialized in medicine, which we are. The high cost of medicine. I'm a doctor. I trained a long time to be a doctor to take care of people, and with that, I want to help the community, and that's really what this is. It's an opportunity to help the community. It's not an expensive thing. Okay, so that being said, about six years ago or so, I have a big family. I have four boys, and realized that my health insurance premiums were high. And that was for a pretty reasonable deductible at the time. I just have always felt that insurance is meant to take care of your catastrophic needs. If I'm going to have a problem, or my kids are, then I want it covered. I don't want it to bankrupt me. And we did have one of those events. And fortunately, the plan worked. I've tested it myself. It works well. But I was paying a lot of money for the plans that had co-pays and so forth. And there's still a place for some, I know. But for us, I realized, man, I could save half of what I was paying every month, go to a higher deductible plan for catastrophic needs, use an HSA, and use this routine care benefit and really reduce my savings. And so I started thinking, others could do this. If we started in businesses, we'd reach the community in a big way. We're going to hit a lot of these folks through businesses. So how it works is, where I am is I might write a couple little things up here. Where I am is here, realizing that we are in a state of high, if you can't see something, or you have questions also, feel free to interject. I'm fine with that as well. High deductible plans. Good stuff. We need these. We need these things. I had a kid, like I said, he had a brain tumor. My 18-year-old, he did very well. We were real nervous. But I had an HSA saved. My deductibles were already in my HSA. I used it as a tax deduction. I could write it off essentially. It was already there. We were out of pocket what the insurance plan was set for. It didn't kill me. That's the thing. And fortunately, it didn't kill him. So but I'm noticing this is the issue. There's a gap. Okay, big gap from here to. I apologize for my writing. Remember, went to med school, so. Yeah. So routine care. So what I mean by routine care I'm an emergency doctor. I'm seeing a lot of this stuff coming in. We take care of a lot of routine care in addition to emergencies. I like emergencies. Kind of morbid, but that's what I train for. Okay, so colds, pneumonias, asthma, allergy or allergic reactions, broken bones, lacerations, all the things that you would daily encounter, mostly 90% of the time. So that's really where we are. But there's a huge gap that's expensive. I'm realizing, you go and you pay for this, and I was doing this for a little bit. I would pay for my kids to go and to be seen, and we were dropping $300 to $500. You walk into the ER, it's where I am, you're going to pay $600 just to walk in the door. I mean, it's just a facility fee that the hospital will charge. Okay, then you have radiology fees, you have labs, you have nursing fees, you have our costs. I mean, you're going to leave with $1,000 to $1,500 bill easily. If you stay in the hospital, $3,000 to $5,000 a day, depending on where you are. It's expensive. Okay, that's catastrophic stuff, though. We'll keep that there. We need that. Routine stuff. How can I handle routine stuff? Well, I also have the privilege of being part of a network of urgent cares here in the Tri-Cities. Convenience. Urgent cares they have their place. They're really convenient. I'm part owner of the one in Piney Flats. That's kind of our hub right now. It's our beta site to use this. So what do? We offer a plan for businesses to bridge or fill this gap. Okay, businesses pay or employees pay if they want to. It's presented $30 a month per each employee or themselves. And when they show up here, whatever their problem is, they pay $35. And I'm going to use copay just because we're stuck on this copay thing. Okay, so copays is another area that I'm trying to. This is really tough to change. So I go to folks and I tell them about this. My folks want a copay. They want to pay their copay, and that's what they want to pay, and they want it covered. It's expensive. It's expensive. Okay, so copays have been around, I think, about 22 years or so. When I was about 1 or 2, it came out, and so I'm trying to. I left copay in there just because that's what folks know, but it's just you pay that. That's your fee. Simple. That's what I wanted it to be. Simply healthcare. That's what I came up with. So, really, I wrote a couple things I wanted to make sure you. I'm not trying to pitch you just using it. Find something right now. I don't know what else is out there. This is a reasonable option to try and help the community. Is using what I have to help the community. We've heard some great stuff today, and one of those things is giving back, and this is one of those things.
Yeah, and I mean to Chip's point, one of the reasons that we started talking is I have a lot of business owners, and like I said, they are really wanting to keep their plan in place, and they feel like that's the right thing. But to do that affordably, they may have raised their deductible and done away with copays, or they may have an HSA in place. How you integrate something like this into a plan like that, it allows kind of a stop loss or a gap on not having to pay so much for your preventative stuff or your routine care, so you're not, every flu isn't eating up your HSA. Because a lot of folks I find on smaller group plans, the HSA dollars they've been socking away gets used because their kid went to a school where they got sick every day, which I've got a 2.5-year-old. I've gotten stuff I've never imagined from preschool. So this is a way to bring a lot of value to plans that still complies with the current rules and regulations, and also allows the employers and the employees to really get that value of the copay. And you'll find if you're in enough group plan designs, folks go, man, my folks really want a $20 copay, and they'll pay $200 extra a month to get it, and then they won't go for 6 months. But that's literally the way you see plans being built. So to design it more efficiently, this is a great thing to implement right in there for your group, or for yourself to even talk, because this is one of those out-of-the-box thoughts. This is one of those blue ocean ideas, and it was birthed from adversity. As we're going through here and we're seeing these issues, this is the opportunity that was grown out of adversity.
So this is available for individuals or just groups?
It's through businesses. I'm operating through business. One, because it's a larger target area. Two, I'm not trying to compete with insurance plans, or I don't want to be known as an insurance plan. I'm not insurance. It's just it doesn't matter. It could be two.
Okay.
Yeah, if
said you don't want to pitch us, but we want to be pitched.
if it's a business, then you can join. That's the thing.
What are the fees again?
The fees are $30 a month. You know, originally
Employee.
per employee, right? And then you can sign your spouse up for 25, and then kids are 15. So they're less, and there is a max after 3 kids you're maxed out. So.
And everything's covered under the standardized, the everyday stuff except for the copay?
Yeah, everything's covered to the standardized. Well, let me preface this too. Now, right now, because it's just starting, if you come in for broken bone, you're going to get an X-ray, you're going to get a visit, you're going to get a splint more than likely, you're going to get a sling or crutches or something like that, right? You're going to go and you're going to pay $1,500, $2,000 for that. For that, our max is 100. Okay, so we max out at 100. So I have to pay the radiologist costs. I have to pay our basic cost. It's all our cost. It's all our costs.
Are there other facilities besides Piney Flats?
There are. I met with actually the CEO yesterday, and we had talked about this before. I said, listen, I'm implementing something, getting this rolling. I've been working on it for a long time. He said, that's great. It'll bring business into into our centers. It'll also show them our centers. If they want, then that's advertising. It keeps things in the system. If they need to, if they have something catastrophic that should come about, they're in the system. He said, we're real excited about doing this. Right now, we're keeping it at one site to see how things grow. So, good questions. Yeah.
A lot of this is, very beta. What we're wanting to do is kind of sit down with, and Chip primarily, I'm attaching myself to it because it's a great idea, is help build plans that are specific to that group. I've tried to talk him into doubling the rate if you have a bunch of boys. But he's not going to do that. Especially if they're under the age of 12, just double that rate right now.
So yeah, no, that's... So the other thing I found is businesses, they are getting to the point where things are too expensive, and eventually they may go away. Well, what do I offer? What do I offer my employees? I need to give them something. This is another option for that. We definitely have niches. This is not going to benefit the subsidized individual who gets everything paid for.
I don't want to ask too many questions, but would this plan impact your rates because you're not going to be using the other companies as much?
Claims, speaking to the insurance side, if you're on a group plan, anytime someone uses care, it's going to go to the bottom line and affect your group rating for underwriting next year's demographics increase.
Because you're using it less.
Because
you're using
if you're using this, it's not dinging your insurance. It's going to keep your experience lower. If it's a self-funded plan, which is typically larger groups, they're always considered by the bottom line because they may have to be reinsured, but at the end of the day, they set aside an amount of money every year, and if they don't have to touch that money as much, the premiums stay or may even lower on a self-funded plan. So this keeps it from dinging those experience or loss ratios that you may hear about in insurance.
And there's several ways to be creative with this also, to just throw this in there or not use this, and just to be creative with your system. And these guys are aware of those, so it's really important to tie into one of them to find out if this is a fit or not. Did you have another question? I'm sorry.
I was saying it's so good it makes you want to get sick.
Yeah. Well, I appreciate it. I hope that the problem is everywhere, Mike, everywhere that I've gone, everyone said that this is a good thing. We know you're not trying to sell us something to make a ton of money. We know you're trying to do something good. The problem is changing that mindset and also recognizing the urgency in that, don't wait until you get the laceration or broken bone or you get sick, and then suddenly you could have paid $100 and you're done. Now you're paying $3,000 or you're hospitalized because they don't go. They're like, well, I'm not going to go. It's too expensive. I'm not going to meet my deductible, so I'm going to have to pay for this out of pocket. So I'm not going to go. And then they're really sick. And those are a lot of the folks I see, now in the ER.
Chip, give them the example if someone comes to you and they do need to be hospitalized. It's something you don't take care of on point.
Right. You mean if it's a catastrophic need and they come in? So yeah. So let's say that someone comes in and they have a need that we see right away that's a catastrophic. We're not going to charge you for that. I mean, if we start doing a workup while you come in and it's a chest pain or I've got some chest pain. Well, we're not sure. We realize we do an EKG. We see some changes on there, still elevation changes. Hey, you're having a heart attack. We start a line. We end up getting nitro. We put oxygen on. Call the ambulance. We're probably going to charge you $35 there. That clinic has to recoup that. That's still way under what would be the cost of your normal visit even there. Okay, so where you benefit, another lead into that too, The 35 is a majority of the visits. That's why I kept it there. The reason we are up on fractures or even lacerations, you'll pay $100. I've got to pay for those supplies. Okay, you're already saving a ton at that level anyway, because you're going to have a $400 or $500 bill normally if you walk into an urgent care, $1,000 or $1,500 if you go to an ER. So it already saves you a ton at that. So that's why that's up. The discrepancy was when you'd come in for, man, I've got strep throat, or I've got a cold, or I've sprained my ankle, or whatever, and you're paying $150 or $200. Well, that's the area we wanted to affect. So that's that 35. That's covered. So that's at $35. So again, how it works, there's an online, at the website, you have an online app. Lori is one of my assistants, by the way. She'll be handling a lot of sign-ups and stuff. She's in the back. She created a form that's going to go online. You'll go to the website. You'll click on the form. You can print it off and fax it, or you can just type in and it'll email to us. Okay, that name will go under that business name. The business will then, whoever signs up, they'll send a check every month for that. So it kind of keeps things. We update a list at the clinic. So when you come in, they have a card. Show it with an ID. This is really me, kind of thing. Pay the $35, go through. If there's anything else that was done, like they had a laceration or a broken bone or something like that, then they pay the additional when they leave. $4 prescriptions written. We have the providers there have the list to know what prescriptions are $4. I use those. They're not just ineffective medicines. They are medicines that are real, that work, that have been around for a long time and lost I forgot even what they call that little patent time. They have a little 7-year time that the drug company has to sell the trade names. And then out the door. Really.
I was going to say, if you want to invite folks to the Lunch and Learns, I know it's not settled yet as to the dates, but if they want to write down on the evaluation form, which hopefully everybody's going to turn in with your contact information, just write simply healthcare on there, and then you can get back to them. And,
okay, that's a good idea.
Are you going to be doing checkups today?
Hey, that's a good question, or a good statement though, because under even the catastrophic plans, your preventative wellness stuff is taken care of. They get free wellness and labs and so forth. I think it's once a year. Is it once or? Okay. I mean, that's awesome. So now that's great for me, because all the wellness stuff can be taken care of, which I love, wellness and preventive medicine. I mean, that's another area I love, but it's covered, so you don't have to worry about that expense for these guys. You're just really handling routine care and trying to bridge or fill that gap. So.
Thank you.
How many physicians or nurses assistants do you have available at your location in Huntington?
Usually in a day, there's two on at a time. Yep, and we have and so if this grows, we have an expansion site there as well. But the goal is to get it to the whole Tri-Cities, where you can walk into one of these centers, show them a card, and they're going to all be familiar with this, and you're going to be able to use their center. It's going to, so it'll be more convenient. My main goal, this is what I really want. This is what I really want, and I think would be awesome for the community. Is I want a one fee. I want it to be I don't want it to be confusing at all. When you come in, no matter what it is, if you need labs, if you have medicines that you need, if you've broken something, $35. I want it to be one fee. I want it to support itself so much that it's just everything that comes into this pool is paying for all those folks to be taken care of. Well, what is that going to make you? I want to take care of the community. I want this to work. I want to try and do something that's different than anyone else is doing, and I want to make sure we're controlling that ourselves, offering our employees something, taking care of their families, offering quality care for really a reasonable price. I don't want to use affordable or anything like that, because it's such a negative connotation right now, but really it truly is affordable. And so that's kind of the purpose behind this.
I think he should be on Shark Tank.
I just want to give him a testimonial. I've coached baseball with Chip forever. He's on the board of the Little League. He's always at the field with his kids. So this isn't a fly-by-night idea. He's had this idea for a long time. I've heard about it before. So he is the guy that's in the community that's involved with the kids. His older kid's getting ready to graduate from Science Hill. He's the one, I believe, that had the brain tumor. We all prayed for him. I mean, it's a miracle that he's okay.
Right.
So
It really was. Thank you.
Yeah.
I appreciate that.
Is that our time? Yeah. Thank you guys very much, and we'll be around to answer your
I
questions.
have cards also,
Give me a form, David.
brochures and so forth. So you guys